Got it. Um, it's not like that. I was very, very lucky in the situation that I was able to seek medical care, not being fully, transparent about what I was going through, but had a safe and healthy pregnancy. I had another pregnancy also while not in recovery and sought no medical care. My thought process was like, I had done this one time and no one had noticed. And like, I'm just not allowed to here. Like, this needs to be something I just handle on my own, which also wasn't a good experience. It was very, very lonely. I felt very isolated. I was in touch with no one. And I didn't really know about treatment. I didn't really know about medication assisted treatment. I didn't really have access to any of that information. For me, I was a very vulnerable person. I was not like self-sufficient. I was not empowered in any way to seek out this information. I felt very marginalized where I was. And really a lot of information could have helped me. I think a lot of things could have helped me, right? So in recovery 2 years ago, I was pregnant. And with 6 years of abstinence-based recovery, like this looked very different. My ability to speak with medical professionals about my concerns, my ability to ask questions, the knowledge that I had gained really from working in a treatment center really shifted my experience. It also made me very selective about my doctor. I chose a doctor who expressed that she understood. I chose a doctor that helped, and wanted to empower me during this pregnancy and wanted to have open communication, and spent more than 6 minutes in the room with me, just kind of doing the ultrasound and being like, see ya, there was more interaction and I felt more able to talk about my reality, and to talk about my tendency to lean towards different, use. But also, I mean, I really could have benefited from a space that someone gave me to talk about what was happening. And really, even like with all of the 18,000 different sheets of paper you get when you're pregnant and you seek, medical care, maybe something in there about like, hey, are you maybe more reliant on substances than you'd like to be? We'd like to schedule a separate appointment just so it feels like a priority. Like I was able to go through a whole pregnancy with no one noticing, drug tests, nothing, while in active addiction. And that, but there's such a fine line, right? Between like, take a drug test, I'll be watching you, and then like, we need to discuss your results. But a person, and I mean, everyone says nothing about us without us. And I 100% agree with that. Like, I feel like there was for me, not really a place where I could ask some questions and talk about some things. There wasn't time, and there wasn't a recovery oriented person. There wasn't someone to kind of like discuss with me the changes I wanted to make. And even the dialogue being more positive, like, hey, is this something that you're not really feeling is something you want for your pregnancy? Like, let's talk about what that looks like. Let's talk about how to avoid all of these mounting fears that you've created based on a lack of knowledge and the social stigma around being a pregnant woman with an opiate use disorder. But yeah, I think my experiences have varied differently as a person in recovery who is empowered with the language, the support, all of those things was very, very different than when I was, a vulnerable person who wasn't seeking therapy for trauma, who wasn't seeing a doctor regularly, because of those fears of judgment and because of that like label avoidance. I was really afraid that if someone knew that this was going to be an ongoing situation for mine and my child's life, and I did not know what that looked like. So yeah, I guess that's just like a brief perspective on my experience being a pregnant person while in active addiction using opiates, and while being a person in recovery with the information and the knowledge and the terminology and the support to really be able to talk about what I needed to get good medical care. Because I mean, in hindsight, I can see that if I had been open, if I had been transparent, I could have gotten the support and care. You know, nobody's watching you drug screen and then has CPS on speed dial. I mean, but those are the images that I cultivated in my mind, being someone who is just very, you know, not empowered and not comfortable using recovery language and not comfortable having a relationship with a doctor. So yeah, that's just a brief addition of my stories with those things. Thanks, guys.
Thank you so much, Taylor. We appreciate that. Thank you for sharing. So now we're going to turn it over to Dr. Townsel and Dr. Muzik to start your part of the presentation.
Awesome. Thank you, Wendy. And thank you so much, Taylor, for sharing your story and just being vulnerable about your experience. I think it's so important for us as clinicians to hear, for the healthcare system to hear, and to really think about how we can bridge those gaps and make sure that we create safe spaces for patients to feel like they're comfortable and able to come to. I want to talk a little bit about the clinic that I run with Dr. Muzik, and really how we want to transition and shift that thinking about, you know, the patients that we're communicating with, our clients, and just thinking about how we do that a little bit differently. So again, the Program for Substance Use Disorders houses our Partnering for the Future clinic. It's a multidisciplinary clinic that cares for patients who have a history of substance use disorder or inactive addiction. And I just want to give a little bit of information as we kind of set the stage for this discussion. So I'm sure you guys are well aware of the prevalence of substance use in pregnancy. We see, you know, this is based on a rate per 1,000 deliveries in the inpatient stay. So anywhere from 24 to 35 patients per 1,000 will have a substance use disorder. And when we look at that base, you know, and break that down by location, we see this higher rate in rural populations. Certainly, we know about the opioid epidemic and higher rates of opioid use in pregnancy, but there's other substances that we have to be aware of, such as cocaine and stimulants. And the reason this is so important, and I think that, you know, Taylor talked about it, is there is associated maternal and neonatal morbidity and mortality associated with substance use disorder. So it's not, you know, just important to say, hey, like, you know, this is a bad thing. It's important to say, hey, we care about you, we care about your life, we care about your health, not just right now, but long term. And we want you to know that there are some things that happen in pregnancy as a direct relation to the substance use that might be going on. So compared to patients with no substance use in pregnancy, we see 2 to 3-fold higher rates of things like preterm birth, preeclampsia, hemorrhage, and placental accreta spectrum, as well as placental abruption. And again, it's just really important to make sure that we have these open communication with patients. It's not just about sort of their current health, but the health of their pregnancy and how their baby will do. So Taylor touched on, you know, a large topic that I think as a healthcare profession and a healthcare system, we have to think about. We have to think about the stigma and the shame and the embarrassment that we sometimes perpetuate and kind of cause. And so we've done a lot of work at Michigan Medicine to talk about stigma, to talk about that public stigma and those images and visuals that are out there. And how do we change those and shift those to really positive images and to really highlight the people that are in front of us? You know, if we break down that public stigma, we still have to think about the self-stigma that patients might continue to have because they've been exposed to that public stigma for so long. So really important for us to think about how we engage patients, to think about the language that we're using, and to really just make sure that we're being as open as possible and keeping those lines of communication open. And, you know, I always want to talk about, you know, why is that important, right? So it's important because, you know, as Taylor mentioned, and so many of our patients have talked about, we see sort of this delay in seeking care because of that concern of stigma and that worry about what people might think or might do. There, you know, and with that delay in seeking care, we can sometimes see higher rates of morbidity, poor quality of life, that isolation, sort of just not feeling in tune with everyone around you, and really a delay in diagnosis of some of those problems that can come up in pregnancy. So I think as we create healthcare systems and spaces that patients feel comfortable coming to, we can start to identify issues if they're present earlier, and reduce maternal and neonatal morbidity. And then just another word of caution, the words that we use matter. And, I don't profess to be like an expert in this, but I do know that we all know how to be kind, how to be respectful, how to be supportive and empathetic. And I think it's just a matter of eliciting that story, trying to understand, again, who is that person in front of you? What is their story? What are the things that they've gone through? And how do we continue to move them forward to the road of recovery? Taylor definitely mentioned this idea of trauma. And so in a lot of what we do in our clinic and really in our healthcare system now, thinking more of a trauma-informed approach to care. We know that patients with substance use disorders have higher rates of PTSD and trauma in the past. And so thinking about how that might have impacted their life and some of their circumstances, and really being in tune with the support, building trust and safety, again, really making sure that the environment is cohesive and supportive for patients. And so I want to kind of now think about the clinic that we have. So again, it's the Program for Substance Use in Pregnancy. This is sort of our website and some of the offerings that we have, but really more so than just a web page and a name. I will come back to this slide. We're a collaborative care sort of model. And it's not just patients with opioid use disorder, but it's patients with any sort of substance use disorder, and even patients who are in abstinence therapy or treatment. We certainly have patients who have come to us in active addiction in the past. We've cared for them during a pregnancy, and then now we see them in a subsequent pregnancy in abstinence, doing well or stable on their medication for opioid use disorder. And so just to highlight some of the things that we do and we think about having a one-stop shop. There's so many concerns that patients have when they come to seek care. And one of those is child protective services. What is going to happen? That fear of the unknown. And so we try to take that right out of the equation by having a social worker embedded in our clinic, available on day one when patients come to initiate care, to answer any questions and to really be open and honest about what their experience has been in the past and what they see for the patient moving forward. We have anesthesia, who has been really important, and Maria will talk about this later, thinking about how we address pain, acute pain and chronic pain in this patient population, and what to expect around the time of delivery. Addiction medicine and psychiatry. Again, and Dr. Muzik will talk about some of the mental health aspects that we see, certainly a co-occurrence of depression and anxiety of about 80% in our patient population. And then also thinking about innovative ways that we can support patients with perhaps some underlying chronic pain or discomforts in pregnancy with physical therapy embedded in our clinic as well. So there's a lot of education that we have just about what to expect in pregnancy, things to look for around the time of delivery, how we're going to support them as parents as they transition from pregnancy to the postpartum period, as well as embedding some support from doulas. We have postpartum doulas for this patient population, just to support. Not every patient has this huge family or supportive friends and family that they can depend on to come and be with them. And so we offer this service just to be another set of arms to rock and hold and to give affirmations to our moms as they embark on their parenting journey. And I wanted to circle back to this idea of harm reduction. So, when we meet patients, we meet them where they are. Some patients are ready and have already transitioned to their medication for opioid use disorder, but some patients still haven't made that decision or aren't sure how to make that transition. And so a lot of what we do is just harm reduction. It's just talking about ways that we can reduce the impact of the substances on the pregnancy and on the patient. Some of that is making sure that patients are aware of naloxone, have access to it. We prescribe it to our patients. We talk to them about medication for opiate use disorder as an option, and sort of let them think about what might be right for them. We have an inpatient addiction consult team that helps us with that transition. So oftentimes some patients might want to come inpatient for that transition to their medication. Making sure they have access if they are experiencing IV drug use, syringe exchange programs, that they know about PrEP, just that they know about some of these things, and talk to them about some of the risks with the way that they administer that medication. And really, the hope is that we just remain engaged with patients, no matter where they are on the spectrum of readiness. Any engagement means care. Care means, we're looking out for any other health risks, and we're supporting them and diagnosing them with anything that might come up. And so that's care that they otherwise wouldn't be seeking or having. And so it's a really important time where patients are often highly motivated to engage with the healthcare system. And so any sort of support and care that we can provide is really important. I want to talk just briefly about, the care that we do provide. So I think, what we strive to do is provide very universal care that we would provide any other patient. I mean, there's nothing different about this pregnancy and the standard of care that patients require and need. We do recommend and, observe sort of universal substance use screening with our questionnaires. And we find that patients who come to our clinic know they're coming to our clinic because of their history of substance use disorders or active addiction. And so we often we'll talk through that. We'll talk about, a urine toxicology and what that means and why we might do that, and how that might even be helpful in their sort of decisioning and planning to parent in the future. I will just take a moment to say that urine toxicologies need to be discussed with the patient. It's not something that we do without having that conversation. And if we get unexpected results in the toxicology, certainly that's a topic of discussion, but certainly not a reason to fire patients or discontinue treatment or care. And so I think it's just important that we have open, honest discussions about what the intent and the utility of those tests might be. And then also just being aware of the current laws regarding child protective services and referrals. We discuss this and have our social workers definitely interface with patients if they have questions. Highly important to do the mental health screening, generally every trimester, just because of the high rates of co-occurring mood disorders and kind of anxiety and depression. And so just making sure we're staying on top of that. And then, as you all know, hepatitis C is now universally recommended, but also thinking about hepatitis B and A, depending on sort of the patient's history and if it's negative, to vaccinate patients. And then also some of the other sort of infectious workup that we do. We do the level 2 ultrasound, and then we do sort of serial screening for growth restriction, which we know is more common in this patient population. And so I just want to touch a little bit on some of the medications that we use. You guys are all well aware of methadone and buprenorphine. Those are opioid agonists that we can use for patients with a history of opiate use disorder. We generally recommend against detoxification in pregnancy. We know that patients who enter into abstinence have higher rates of relapse. And so talking about when the time is right to perhaps enter into abstinence and what some of the concerns might be is really important. We certainly have patients who want to decrease their methadone or buprenorphine doses in pregnancy or come off altogether. And those are just shared conversations that we have. And then, as Taylor mentioned, just the idea of neonatal opioid withdrawal syndrome, we have open discussions about that. Certainly, we know that rates can be as high as 50 to 90% if patients are on methadone, a little bit lower, kind of like 30 to 40% if patients are on buprenorphine. So just having discussions about what that looks like and the supports that we have in place. I'll talk briefly just about smoking. We do have about a 70 to 80% co-occurrence of nicotine use. And so I often will tell patients, instead of coming down or coming off of a medication for opiate use disorder, because that the dose of that medication, it doesn't really correlate with how the baby's going to do after delivery. So coming down a bit doesn't mean that you're reducing the risk of opioid withdrawal syndrome. You're still on the medication and the baby's still being exposed. But we do know that if patients reduce or quit smoking in pregnancy, that has been shown to reduce the risk of neonatal opioid withdrawal syndrome. So we do focus a lot on smoking cessation. And we have some like in-house referrals that we can send patients to help support them with that cessation. And this is just that tobacco consultation service. It's kind of like a 6-week program, helps patients choose a quit date, and talks to them about some of the treatments that they can use, the patches, the gum, the lozenges. We prescribe those, but they can also get those through this service. And so just another support for patients. A little bit about education. So again, the maternal mortality rate in the United States, we know is skyrocketing, and some of that is due, unfortunately, to accidental overdoses. And so we often will bring this up. This is like an information sheet that we give to patients. We talk to them about the use of Narcan, their access to Narcan, and whether they know how to use Narcan, and then we prescribe Narcan. So we just, this is just another opportunity. And many patients don't see themselves as having sort of acute concerns with overdose, but perhaps they know someone else or someone in their community. And so having it on their person or in their home could potentially save someone else's life. And so we still encourage patients to have access to it, and, just make sure that they're educated about how to use it. One of the last things I want to kind of focus on is our Eat, Sleep, Console program. We are now about 18 months in from implementation. This program really focuses on the mother-baby dyad staying together through the postpartum period. Historically, we would separate moms and babies. Babies would go to the NICU for monitoring, Finnegan scoring, and sort of have these long extended stays as they transitioned to oftentimes opioid treatment for their withdrawal syndrome. But we're now really encouraging breastfeeding. We're encouraging moms and babies to stay together. The dyad is admitted for 72 hours to, assess for any signs of withdrawal. And really, we're making sure that, is baby eating well? Are they able to stay asleep for an hour at a time? And are they able to be calmed within 10 minutes? And we talk to patients about this program well before they deliver, so that they have information about what they can do to support their baby in the postpartum period if there's any evidence of withdrawal. So I think, this implementation has led to, now we have had, I want to say in our clinic, 0% admissions to the NICU since implementing this program, and a significant reduction in opioid use in neonates. And so I'm going to transition it to Dr. Muzik to talk a little bit about how she supports us and our patients. She is fabulous and such a joy to have in our clinic.
Thank you so much, Cortney, Dr. Townsel. This is lovely. And I so appreciate working in your clinic because I think that you really embrace kind of this idea of nurturing the family, nurturing the mom so that she can nurture the unborn baby and then the born baby, and kind of, enter this journey of parenthood and motherhood as best as she can. So with that, I want to kind of briefly speak about, the importance of thinking about mental health in addition to the physical health that Cortney talked about, and the support in recovery through medication-assisted treatments and having these open discussions, to also focus in on mental health in pregnancy and postpartum, and kind of as a start to think about, well, is mental health in general a common occurrence in the peripartum period? And in fact, it is. So even for, any pregnant person or postpartum person, the rates of depression, anxiety, bipolar mood disorders, psychosis, are not uncommon. We know that the base rate for depression in pregnancy or postpartum is around 15%. And depending on risk in the family or in the personal history, or the risk exposed through external risk factors, psychosocial factors, life experiences, this rate can go up to 40+%. Similarly, anxiety, approximately a third of moms have experienced, sub-threshold or clinical level depression. And with COVID and with all the stresses in the recent, time, this has just been rising. One word about the blues, this is almost like a normative experience due to the hormonal drop after the labor, that many persons experience that mood instability in the first 1 or 2 weeks after the birth, but usually that might diminish, and no really medication treatments are necessary. But for some, it actually is the precursor, or it worsens and becomes then manifest severe mood instability. And particularly individuals with pre-existing bipolar illness or pre-existing psychotic illness, although the base rate is 1% in the population of these illnesses, if you have a pre-existing condition, this is the time to really hone in on, think about, is this a time to vary and to monitor. And then we talked about trauma. Just in the general population, rates of trauma, interpersonal violence, either in childhood or as adult interpersonal violence, rates are around 20–25%. So the chances are quite high for a woman to have these experiences that then might lead into a condition that we call post-traumatic stress disorder. So the baseline rates in the United States on PTSD is around 3 to 7%. And even women, even independent of interpersonal violence, birth trauma, perinatal losses are traumatic experiences that might lead to a traumatic PTSD development. And then rates of substance use, as we think currently, 5% of women in the general population are using some kind of substances. So I just put this out there because I looked up the numbers. If we have around 3.5 million births in the United States annually, these are huge numbers of persons who are suffering. And so really we need to hone in on these mental health conditions. And now when we think about, next slide, when we think about that, in individuals with substance use, often these things are co-occurring. If you click again, you see these comorbidities between 30 to 60 to 80%. So it usually, in my experience, or in our experience in our clinic, women come with trauma, other social determinants of health, depression, anxiety, they might have PTSD, and then often there is substance in the mix, often as either due to being introduced to it from, intergenerationally, or as a self-medication at some point to cope with all the trauma and the mood issues. But we have to understand that these are co-occurring circumstances, and we have to tackle them all if we want to be helpful. And with that, I want to hone into what Cortney already spoke about, that a trauma-informed lens in our care is critical. And what does that mean? What does trauma-informed lens mean? It means that we understand that trauma is ubiquitous, that it's highly prevalent, that women have high chances of, and families in general, in stress, that there's trauma just intergenerationally, interfamilial. And that one of the most important aspects that we need to do, and Taylor spoke to that as well, is to create safety. Because only in the moment of safety that you feel, that you create through transparency, empowerment, being reliable, being respectful, being honest, only in this context of safety can you seek help and be be successful in this journey to motherhood. So that also means that cultural humility, to understand where this person is coming from culturally, from their family background, from their environment, their neighborhood, and be responsive to their needs and meeting them where they are. It means that we have to be trustworthy and dependable. We cannot, we have to challenge ourselves that we are the persons that we are wanting to be at any single encounter of our patient care. Collaboration, empowerment, compassion, empathy, not feeling burned out, checking ourselves that we don't come across disrespectful or impatient or angry. And that means that we need to take care of our own burnout as well. And we know right now, we see when we look at surveys around our own staff and faculty at Michigan Medicine, how challenged the staff and faculty feel themselves and our risk of burnout. So it's really important to kind of think about ourselves as providers so we can actually work towards our own standards, so we can be nurturing. I want to say one word also about what trauma does. We have lots of data, clinical wisdom, as well as research to show that trauma exposure changes a person's worldview. It shatters their assumption of relational trust. It shatters their own perception, or it may shatter their own perception of self-efficacy and kind of who am I and how worthy do I feel? How lovable do I feel I am? And that might create social isolation, that I'm withdrawing from others. I'm not trusting. I'm not feeling that I deserve, that I am, and that might lead me to withdraw and be depressed or be anxious and kind of be more emotionally dysregulated, which then in turn changes my behavior, how I approach the world, including how likely I am to have positive and benevolent assumptions of providers, how they will treat me. And often it's a vicious cycle. So help-seeking behaviors are often lower in the clients that are that have been traumatized prior, and then they get re-traumatized through the healthcare system. As said, this all might lead to mental health problems, and that does not help with parenting either, because then you are isolated by yourself, maybe overwhelmed, like every other person who is entering parenthood, but now you're on your own, maybe with a baby who also has some withdrawal symptoms and might be temperamentally a little bit more difficult. So this is the time where you need more help, not less. And often, as Taylor was also speaking to the fact, you feel so alone. So with that said, our clinic is also very much wanting to support this parenting journey. In addition to the mental health, also the parenting journey. And we use a model that our team has developed previously. It's called, it's based on kind of an attachment-based model called the Strong Roots model, but the specific group for the moms is called Mom Power. They named it themselves. They was developed now over 10 years. It's a 13-week manualized attachment-based trauma-informed parenting and mental health group intervention. 10 weeks of group, 3 individual sessions that have these core components around self-care and parenting and kind of coaching around mother-child and parent-child interaction, but also connecting to other services, social connections, all in the spirit of enhancing trust and helping with help-seeking, learning to regulate your own emotions so that you can be the best parent you want to be. Because I was so amazed, and that resonates my experience, what Taylor said. Every mom is excited about being the best mom that she wants to be and being excited about being a mom. But we need support, like all of us, we need support in parenting. And so engaging our patients in a parenting intervention. That's also something that we are now offering or doing. Okay, next slide. One piece that I also want to talk about that Cortney addressed is pain management and thoughts around pain. Pain management is a little bit more complex in pregnancy, labor, and postpartum for those who are on medication-assisted treatments or are in active use, given that the substances are maybe, in some way sensitizing or desensitizing the receptors that are for pain medicines, that are also meant to be targets for pain medicines. But we know that actually these medication-assisted treatments are not serving like analgesics, that they are not really taking away the pain. So women might experience pain during labor, but not given the adequate dose, or might be given too much, and that might sensitize them in terms of their own worry or for relapse or for using it even more. And we actually know that from studies that when you look at the data up there, there's just kind of just to do a brief kind of glimpse that if you are on a methadone treatment, you need higher levels of pain medicine as when you are not, in order to have the same adequate pain management. So with that said, this is a very important to monitor this and have experts, anesthesia and OB work here hand in hand to have experts guide and support this process and alleviate a lot of the anxiety that women bring during this time period. And so actually we, our team here at Michigan Medicine, together with our colleagues from anesthesia and with colleagues from Beaumont Hospital, we just recently received funding to actually develop these guidelines for a really systematic, appropriate, patient-centered pain management, and to package it with a comprehensive holistic patient care that addresses physical, mental health, recovery, as well as parenting. So we are just kicking off kind of this programming in January and want to test whether this model that we are developing with feedback from the moms who will go through this program, whether this is effective and acceptable to them. And we welcome all of you. If you have someone who you think would benefit from this model, please send them to our clinic. So that's all what I had to share. Thank you.
Thank you, Dr. Muzik. And I know some of you have questions in the chat. We will get to the questions at the end of our presentation. We have saved some time for that. So let's talk about women-specific services and requirements. Home and Vision is the designated SUD treatment provider through the PIHPs in the state of Michigan for Washtenaw County. And so what that means is that each year the state sets aside a minimum amount of money that is specific for treatment and ancillary services for eligible women. Eligible women are defined as pregnant women and women with dependent children, including women who are attempting to regain custody of their children and are addressing substance use disorder. And so just with everything we've talked about with Taylor and Dr. Townsend and Dr. Muzik, women have a very specific need when they're pregnant or when they're addressing addiction and raising children. And so we want to ensure that we have those services available to help support them, help them connect to services, and help them make the experience by empowering them and supporting them through the pregnancy. Pregnant women, women at risk of losing their children due to substance use disorder, and women with an open CPS case are identified as priority populations. They are screened within 24 hours of initially contacting our Washtenaw CMH access team. And then the provider has 48 hours to get them into treatment or get them referred to treatment. When we look at what that means, or the definition of women-specific service requirements. It means having values that are incorporated into women-specific services. So our team at Home and New Vision, we have a women's specialty service team at Home and New Vision, and they are trained to work with women. They are trauma informed. They have background in substance use disorder. And it's comprised of our outreach worker, our case manager, and Taylor, our peer recovery coach. And what their goal is to really support women with ancillary services and remove barriers so that their treatment can be effective and help meet the needs so that they can be successful towards their goal towards recovery. So when we're working with those individuals in our program, we look at having a family center approach, not just supporting mom, but helping her support her children or help support her through pregnancy. We look at family involvement and looking to see what family they do have that we can help bring in and help support that process. Building on natural and community support. So connecting with Dr. Townsel's program and Dr. Muzik's program, looking in the community to see what other supports are available to help them connect with other women who are experiencing the same situation. We focus on strengths, helping them find and realize their strengths. A lot of the times, they don't see their strengths when they're in these situations, and it's really hard to come up with them. So our role is to help them identify those strengths and empower them so that they can be successful on their journey. Unconditional care, not having judgments, welcoming them, being respectful, and treating them with care and dignity. Collaboration across all systems. And this is really important for us. One of the things we really do try to do is when women are coming in and they are involved in CPS or DHHS cases, they don't understand a lot of the times what a case plan says. They don't understand what their goals are. They don't understand what they need to do to reunify or to keep custody of their children. Our role and our job is to help them and connect with CPS and foster care and help walk with them in that journey so that they can truly understand what their expectations are and advocate for them. We use a team approach across all agencies. Sometimes our women are involved in more than just MDHHS. Sometimes they're involved with probation, or they have other things that they're dealing with that was a follow-up from their substance use. So we're working with everybody who's involved in their situation so that they can come out of this ahead and move towards recovery in a successful way and also feel empowered. We want to ensure safety, making sure that they feel safe and that they feel connected. We make sure that we have a gender, age, culturally responsive treatment program. And we'll talk a little bit about our women's group that we're getting ready to start. We're very excited in September. We look at self-sufficiency. So sometimes they don't have transportation or they're not sure how to get to where they need. So while helping them with transportation, we're also empowering them to learn the bus system or utilize their transportation through their Medicaid. So just finding ways to help give them the tools so that they can feel empowered and feel self-sufficient in their journey. We provide education and work focus. So looking at those strengths, getting them connected to resources for employment. We believe in their growth, their learning, and their recovery. And we make sure that they feel that and they know that when they're working with us and when we're working with them. And we're really outcome oriented. We're assessing those barriers and slowly checking off that list with them as they start to remove the barriers and start to move towards their own recovery. When we look at our services, what we provide is a wraparound care approach. As shared, we have our recovery peer coach at services, case management, and clinical services. Our clinical staff are focused on recovery. Most of them, soon to be all of them, are working on being trauma informed and working on more trauma informed care for our clients. As Dr. Muzik mentioned, trauma is a huge piece for women. Women experience a lot of traumas when they're involved in substance use disorder. And we really want to make sure that we're taking the right approach when we're working with them. Meeting the client where they're at is huge. As Dr. Townsel shared, when our clients come in, we want to meet them where they're at, whether they're ready to stop using or they're working on reducing, whatever they are in their care. That's what we want to focus on using harm reduction approaches. and looking at using evidence-based practices such as cognitive behavioral therapy, dialectical behavioral therapy, motivational interviewing. And we're very fortunate. We welcomed an art therapist to our team back in April. So we've also been able to incorporate art therapy as well, which has been very beneficial. And then we have a recovery group that is just focused on women and women topics, which will be in person. So we're really happy. So we are very, very excited to bring back our Women in Recovery group. And this is just an overview of some of the areas that we'll be focusing on that we see and the women we've worked with. And so introducing them into recovery, helping them identify who they are. We have an art therapy exercise that really helps focus on opening up and looking at where they are and who they are. What are their own expectations of their recovery? And this falls along the lines of meeting them where they're at, helping them navigate those feelings around recovery. There's a lot of feelings when we're working with these women, and a lot of the times they don't have a real great way of expressing them. So we want to help teach them how to handle those emotions, those feelings. Setting them up with tools for success, self-care, meditation, and mindfulness. Looking at relationships. A lot of the times the women we work with, they do come from very difficult relationships. And sometimes they don't understand codependency or what a healthy relationship looks like or what an unhealthy relationship is. Managing stress and looking at trauma. And then, of course, in week 16, the celebration, because we want to celebrate each and every one of them and the success that they were able to make in completing the group and making that commitment. So that's a little bit of an overview for where we are and what we're doing in our program. And I'm going to let Taylor talk a little bit about what she sees and what's happening at our level. So go ahead, Taylor.
Thanks, Wendy.
Yeah.
So in a practical sense of working on the women's specialty program team, we are basically able to provide the services I wish I would have had. You know, we are able to watch people's children so they can make their appointments, which a lot of our parents are single parents. They have transportation barriers, they have childcare barriers, and even, you know, safety with the people they have to watch their children. Like, they can come here, we know who their kiddos are, we play with them, they're, you know, they play with each other. It's a nice environment that's positive and supportive for people to bring children and to sort of just say, like, I get a minute to engage in therapy, engage in recovery services, engage with my case manager, and do these things without having to worry about the safety and well-being of their children. So that is a huge, that's one of the highlights of our program, I think, is that we are really able to allow women to come and be present and participate in their treatment. We each have goals we work on with the clients, and they're person-centered goals. It's not, I would really like to see you do this, this, and this, but it's people talking about what's working for them or things they're interested in trying or things that they would like to work towards, and really doing those things with our clients at their pace. And kind of seeing where they are and what they would like to try. We can take clients to recovery meetings in the community. There's a lot of fear around showing up where everyone seems to know each other, and a lot of sitting in the parking lot and not going inside. And we have the freedom in our program to sort of break that barrier. We have case management who takes our clients to get clothing for their children, go to food pantries, just do these sort of things that would be a lot more challenging if they were on their own. So they come in and, you know, they get calls from all of us, which feels like 30 to them and is really about 4 of us, but they get very involved with us. We're very involved with each other. If I am meeting with a woman who identifies a need for housing, or she's uncertain about her health care, that's a conversation with, you know, our case manager. We work really closely together to make sure that we're not missing people letting us know what they need. Reducing stigma and supporting where people are at is huge. I think that it's incredibly beneficial to have people who are loving and caring and understanding. And I think it's also very important to have someone with similar experience, someone who's in recovery, someone who shares the guilt of someone parenting after they, were in active addiction. We also provide reminders and transportation to medication assisted treatment appointments. We have clients on Sublocade. We're helping them get there. We are making sure they remember. We are keeping track of their appointments and really just providing all around, services to all of our women. And this is a safe space. People tell us all kinds of fun things, and we are in touch with therapy when we need to mention something. And we are all in touch with each other and have really good communication and are transparent with the clients about that, is that we are a team. We're here to help you, land where you would like to and start getting there together. And a huge piece of what happens too, I think, with moms, like their self-care is lacking. We provide things to clients here. We have diapers, we have lotions, we have all types of different things that we have meditation books. It's just a large variety of things that we're able to help people with based on kind of where they're at, and to really have those conversations about, I feel guilty for all the things I've been doing. Now, how do I parent? And to have open conversations about those feelings, A, being normal, and B, being something that we can, look at how to tackle together, as opposed to the cycle that just perpetuates itself of guilt and then letting your kids do whatever they want, and then being sort of at the mercy of your children and not being able to take care of yourself. These are really common conversations that we get to have with our clients on a regular basis. And it's a place where they feel safe to bring those things up. There are definitely medical concerns that women have medical concerns, but also some of this other stuff that doesn't seem as pressing. I need housing, I need to see the doctor, but also I feel like a terrible parent today. And like, how can I parent through that and become an empowered woman and become an empowered parent? So we get to show up in a wide variety of ways. Our case manager was at the birth of one of our clients' daughters. I mean, we are everywhere, and we try to be everywhere and be available for what people need. Along with like what Wendy said, which is empowerment, teaching people how to get to these things, showing people where things are, connecting women with other recovering women who have had similar experiences with parenting and, being pregnant, and all of that stuff is really getting them a network of support to kind of combat that isolation feeling, and just sort of the things that come along with that, and the self-talk that gets really negative, and the lack of self-care. And just all of these ideas that women seem to have as parents is that I'm not supposed to take care of myself. I'm not supposed to do all of these things. Like, my role is to take care of children. And we're here to just say like, no, you need to do this other stuff too. And like, what are some things that you think would help? And like, let's work on those things. It's a really, really cool program. We are definitely, like Wendy said, wrap around. We are as involved as clients want us to be. That being said, we're not showing up on doors, knocking, asking to hang out, but if people are asking for support in certain areas, we are ready and willing to provide absolutely everything at our disposal. And also constantly looking into new resources, new housing options, new, food banks, just a variety of things. We try to be as well-rounded as possible and to be as connected in the community as we possibly can.
Thank you, Taylor. So I guess now it looks like the questions in the chat have hopefully gotten answered for most of you, but we'll go ahead and open it up for any other questions. Either.
Hi. I don't have any questions. I just want to say that this was an amazing session. Personally, I started my recovery journey at University of Michigan Hospital, being transitioned onto MAT treatment by Dr. Juni. And then I came through the women's specialty program. I did family transitional housing. And if it wasn't for like all three of those things, I probably wouldn't be in recovery and now working at Home and New Vision. the University of Michigan Hospital, even though they didn't have this program at that time, they were amazingly understanding of me being a pregnant woman addicted to opiates, coming there saying, I want help. You know, they didn't, most of them didn't make me feel, you know, less than, because I was reaching out. And it's really because of them and their understanding of what I was going through that like allowed me to be a parent and change my whole life. So I just think that this is amazing, and I will definitely keep that program in mind if I run across any clients who are in that situation, because the biggest stigma for me was, am I going to lose my baby? You know, and because I was doing the right things and working with U of M the way that I was, I got to keep my baby with only 45 days in recovery. So you guys are amazing. Thank you so much.
Thank you, Rebecca. Any other?
I have a question. My name's Connie Shuby. I work at Trinity Health and Substance Abuse. About the Women in Recovery group, you said it's open to women who are currently receiving SUD treatment. Does that mean only within your system or any system?
Washtenaw County,
Okay,
but it is open. So if there's individuals with private insurance or through the Medicaid system, both would be able to attend.
okay. And is there a charge for this?
It's covered usually through the insurances.
Okay, okay. So would they be billing? Okay, this is kind of a strategy question here, billing
Okay.
question. If they're receiving concurrently, you know, let's say they're in outpatient treatment here at Greenbrook in Ann Arbor
Okay.
through Trinity Health, and we're billing through substance abuse. And then they're billing again through substance abuse with your facility. I don't think that can be done.
It can be. So the way we would do it is they would contact Access and we would just request a group only service code.
Oh, even if they have private insurance.
If they have private insurance, we would be billing to the group, so it should still be acceptable.
Okay, but we couldn't bill them for our group then.
Yeah, I guess that would be an insurance question. We'd
Yeah.
have to, yeah.
Okay, so
Yeah.
if we did individual work with them, that'd be fine because it's a different SUD service. Okay. Because this is this is just group. But if they're CMH or through Access, they'll work that out through the system.
Yep,
Okay.
and our, on the flyer is the contact for the person who will help them get connected and get that situated.
Okay. Okay. It just has a phone number. It doesn't have a particular name. Was it supposed to have a name?
Yeah. It's the email, it's Hannah and it's hcua@homeanddivision.org.
Okay.
If if you email her, she'll be able to get connected with the person and help them get set up.
Okay, great. Perfect. Thank
You're
you.
welcome. You're welcome. And then I'm also, I had some questions kind of about how women's specialties works. I'm actually going to put the state TA 12, which explains how that funding works and who's qualifies. I'll put that in the chat as well for those of you that were asking about that. I'm just looking for it on my computer real quick. Any other questions?
So,
Hi.
oh, go ahead.
I'm Darlene. I am the person who wrote the question about the funding and also about various modalities, somatic care, and the other bunch. First of all, thank you all. This has been a really great presentation. I'm a person in the community and I get people help or whatever. And my biggest concern, well, anyways, it's a totally different topic, but I just wanted to find out from you, Wendy. I know we're talking about pregnant moms and children But does this block grant also cover other women if they're not pregnant?
If they have, it's specific to women with children or women who are pregnant.
Okay.
We also have recovery support services at Home and New Vision, which is services for case manager and peer recovery coaches for women without children. It's just a different funding.
Yeah. I'm very familiar with Dawn
Okay.
Farms and Home and New Vision and all that. And a lot of times it's hard to get the care because if they don't fall under one of those two categories of insurance, it becomes frustrating to try to get the help that people need. And I do appreciate that Dr. Muzik said that it's free and all of that. So I guess I'll ask more questions about that. Do you know about the somatic, I know you talked about trauma-informed care. Are you doing other modalities like EMDR and somatic therapy?
We are not at Home and New Vision at this time. We don't have anyone trained. We're more TFCBT focused or DBT.
Okay.
So at Michigan Medicine, at PFF, our providers are trained in peri-DBT for emotional regulation. They are trauma-informed, like we have EMDR therapists. We do child-parent psychotherapy, Alicia Lieberman, which is trauma-informed. Some of our, we use some strategies like from somatic treatments, like, body cues and internal, but nobody is trained in the parts of all your healing model or whatever that somatic treatment is. So nobody's trained in that.
Yeah, well, that's super helpful. And I had sent you a private message, which I'll send you an email about care and wait lists and all of that. It's a bigger concern, and I don't know if there's a single solitary answer to that as far as getting care either at a local rehab or at a hospital. It's really, we just need to do something. I mean, I understand there's maybe a 2-week with the pregnancy thing, but with other care for people, it's just way too long of a wait list and people are dying. And it's very frustrating for me as a person in this community trying to help people. So that's all I need to say. So if you want to speak to that, that would be great. But again, really great job, you guys. And Taylor, congrats.
Thank you.
Well, I just want to comment briefly on the wait list, and I am well aware. I mean, the community is stressed. The system is overloaded, and I don't have any excuses for that. I can only tell you the providers are overloaded and stressed as well. I cannot speak to the overall Michigan Medicine mental health treatment wait list, but I can tell you that the pregnant and postpartum community, both in the perinatal mental health clinic as well as in our Partnering for the Future clinic, that the wait time is around 2 weeks. We have a priority to get them in within, I mean, if 4 weeks would be the max, because we know it's a time sensitive period. So I'm not sure if there is any, and this is an open invitation, if there's anyone you try to get into mental health treatment who is pregnant or postpartum with mental health issues and substance use, and you are waiting longer than 4 weeks, please do email me.
And I'll just share too, Dr. Muzik. So Home and New Vision has actually expanded our services to include mental health as well as substance use disorder. And we do not have a wait list right now. So we are an option for both our residential short-term program as well as our outpatient services. Also, we are putting together a Washtenaw County substance use resource guide. It should be ready and printed by October. So I'm going to put my email in the chat for any agencies that are interested in getting some copies of that. We're anticipating ordering between 10 and 15,000 copies. So we'll have those available. Hopefully that will also help get people connected to the right place. So I'll share that now too. And I saw one hand up. I don't know, Ruby, did you want to ask your question real quick and then we'll close? or was it?
I had my hand raised, because I did have a question, but I'm not sure if this is the proper forum for it. What about help for single fathers that are experiencing substance use disorder or are solo parenting because their child's mother has substance use disorder?
That is a great question. They actually qualify for our women's specialty program if they are the custodial parent and they are fathering the children.
That is absolutely awesome.
So,
Well,
okay.
that's really good to know. Wow.
Yeah, sorry, I should have included that as well. So, but in that information is also in the PT-12 Women's Service manual that I just put in the chat. So that'll really answer all your questions for which populations are covered and how the funding comes to us and what the expectations of the program are.
I just wanted to make a comment, very sensitive to the idea of being able to get patients in as soon as possible. And like Dr. Muzik mentioned, certainly trying to get them in within 2 weeks is the goal, but we have often been able to get patients in within 72 hours or just depending on the day of the week. Our clinic meets every Tuesday afternoon. And so Maria and I are there. And if we're able to put someone on the schedule, we will. We'll come in early, we stay late, we do all of those things to accommodate our patients and to make sure that we have that safe transition. So definitely feel free to reach out to us directly, have patients call, but we are happy to facilitate getting patients in the care that they need.
All right. Well, thank you, everyone. We appreciate your attendance today. Thank you, Dr. Townsel. Thank you, Dr. Muzik, and thank you, Taylor. And hope everyone has a safe and happy holiday weekend. So thank you.